Hi, everyone. Welcome to this webinar on scenario-based health impact projections for the Gaza crisis, which is co-hosted by the Health and Humanitarian Crises Centre at the London School of Hygiene and Tropical Medicine and the Johns Hopkins Center for Humanitarian Health. My name is Michelle Lockett, and I'm one of the co-directors of the Health and Humanitarian Crisis Centre, along with Karine Vanderboer and Neha Singh. Today's webinar will cover recent scenario-based projections of excess death in Gaza. As we know, the current Israel-Gaza war has had an immense humanitarian impact. Approximately 75% of the 2.2 million Palestinians are displaced, and most reside in overcrowded shelters with limited access to water, sanitation, and food. The provision of healthcare in Gaza is extremely limited. The projections that we'll share today were developed through a collaborative research project between academics from the Health and Humanitarian Crisis Centre at the London School of Hygiene and Tropical Medicine and the Johns Hopkins Center for Humanitarian Health at the Johns Hopkins University. The research is being conducted with the support of the UK Humanitarian Innovation Hub and the donor, the UK Foreign Commonwealth and Development Office, FCDO. On the next slide, you'll see some QR codes where you can sign up to receive newsletters from the Health and Humanitarian Crisis Centre and the Johns Hopkins Center for Humanitarian Health. Just to let you know a few housekeeping pieces before we kick off. Today's webinar is being recorded. You're welcome to participate through adding questions using the Q&A function on Zoom. You can also vote on questions as they come in and as others add them. You can also follow us on Twitter, and you'll see the Twitter handles for LSHTM Crisis Centre and the Johns Hopkins Center as well on the slide. I'm now going to hand over to the co-director of the center, Karine Vanderboer, who will introduce each of the speakers. Thanks, Karine.
Thank you, Michelle. I'm going to give a short bio information for each of our speakers today in the order in which they will be presenting. So first, we'll be hearing from Francesco Cecchi, who is a professor of epidemiology and international health at the London School of Hygiene and Tropical Medicine. His research focuses on quantitative public health measurement and disease control in crisis settings. Then we will hear from Dr. Sara Ali, who is a master's student at the London School of Hygiene and Tropical Medicine and a global emergency medicine fellow physician at Yale University. She is interested in emergency medicine in the MENA region. Zeina Jamaluddin is a research fellow at the London School of Hygiene and Tropical Medicine. Her research focuses on child and household level food insecurity, water insecurity, and malnutrition among refugees and marginalized populations in the MENA region. Dr. Fiona Majoran is an assistant professor at the London School of Hygiene and Tropical Medicine, and her research focuses on water, sanitation, and hygiene. We will also be hearing from Hannah Tong, who is a research associate at the Johns Hopkins Bloomberg School of Public Health. Her research focuses on maternal, newborn, and child health. We will also be hearing from Jishi Chen, who is a doctoral candidate at the Johns Hopkins Whiting School of Engineering. Her research has a particular emphasis on mental health issues arising from conflict and trauma. Dr. Hanan Aboukmail is a physician and a research fellow at the London School of Hygiene and Tropical Medicine. She is interested in healthcare quality improvement. And we will also be hearing from Paul Spiegel, who is a professor of practice in the Department of International Health and director of the Johns Hopkins Center for Humanitarian Health. His research focuses on humanitarian health and migration with a focus on the refugee crisis. Other people that have been mentioned in this slide are Greg Barnsley, Una Campbell, Tak Igusa, and Shada El Nakib, who have also been key in developing this project. I will now be handing over. Thank you.
I think it's me, isn't it? Right. So
Apologies.
I'm Francesco. No, that's all right. That's all right. It's no. Hi, everyone. Thank you for joining, and thank you for the introductions and for setting up this important webinar. The first thing I'd like to start by acknowledging is all of the work that many people did, largely pro bono in support of this project. And this included a lot of students and staff at both institutions and elsewhere, as well as people around the world who gave in-kind contributions, including, for example, to help us design a website, or perhaps to help us figure out values for different parameters. In short, a whole range of support that we're really grateful to have received. Next slide. And before we get into the actual analysis, I think it is just important to acknowledge that it isn't just many people who are dying in Gaza. These are individuals. They're all individuals, and we have just put up here a few pictures and names of people from Gaza who have lost their lives in the last 5 months or so, and some include literary scholars and poets. And here's a very nice section of a poem written by a Gazan poet that I think you can perhaps read for yourself. We do really struggle to even ourselves keep in mind that at the end of the day, each and every one of these numbers that we are counting is a person with a family and loved ones and a whole life. Now about the project, what we really wanted to do here is to inform decision makers, both humanitarian as well as diplomatic actors. And the way we wanted to do so is to really put some evidence behind what might happen in different scenarios or under different trajectories of how this war, this crisis will evolve. I have been saying in the media work that we have been doing that, in a sense, what we want to do is to put human lives at the center of the equation of decision making. And we want to make sure that when decisions are taken, whatever those decisions may be, they are done on the basis of some evidence on the likely public health impact that those decisions will have. Obviously, when we look at impacts, we can think of any number of dimensions. However, we picked mortality as the single most downstream ultimate indicator of what happens in terms of health terms to a population that is affected by this kind of crisis. And specifically, we are trying to project excess deaths, that is to say, above and beyond the level that would already occur in Gaza if there were no crisis. We also have, from the very start of the project, insisted on transparency and reproducibility. So if you go to the website, which I will signpost in a moment, you will see that all of the data, all of the methods, and all of the statistical code that we have used is available for people to reproduce and criticize. Lastly, of course, we received ethics approval from both institutions. Next slide, please. So again, I mentioned that we do have a website. Many of you will probably have seen it already. We also have an email that you can write to and a QR code, as it turns out. And if you go through the website, you will see a set of products. Obviously, the main report itself, but also a detailed methods annex, summaries in Arabic and Hebrew, frequently asked questions, and the data and software, as well as a whole repository of reports and data that we have been collecting. And the plan is very much to provide updates with time. So this is hopefully not a one-off, but something that will be followed by an update later on. Next slide. What did we actually do? Well, as I mentioned, we looked at scenarios, specifically 3 scenarios. We wanted to represent a likely range of how things would evolve in Gaza, from a relatively optimistic scenario of a more or less permanent or long-term ceasefire, to all the way to a pessimistic scenario of a further escalation of military activity in the Gaza Strip. And the central scenario has been for us very simply a continuation, more or less, of conditions experienced between 15th and October and 15th January, that is to say, more or less the period to date. Now, for each of these scenarios, what we have done is really looked at a number of dimensions, and we have quantified specific values of risk factors and health service disruptions that are pertinent to different diseases, different health problems, as part of spelling out what these scenarios actually are going to be. The time frame for the projections is 7th of February to 6th of August, so 6 months, but we have looked at 2 equal-sized subperiods within that time frame. Next slide. Essentially, what we have got happening in Gaza, as you will appreciate, is direct effects of the war due to aerial and ground warfare, which are resulting in excess deaths, but also all the indirect effects of the war, which people really hadn't been quantifying up until this project. And these, of course, reflect key risk factors, including poor shelter, disrupted or non-existent health services, very insufficient water and sanitation, and critically, very insufficient food. This is something that worries us a lot right now. Now, that could also result in epidemics, but generally, we understand that all of that will result to some extent in different ways in indirect excess mortality. Next slide. So now, in addition to the scenarios, which provide one dimension of our work, another dimension is different health problems that we stratified our analysis by. And essentially, we divided our work into modules, which we will tell you about during the presentation, and which you can see listed here. What you can also see on this table, which I won't read, is the specific diseases or health problems that were actually taken into account within each of those modules. In addition to these so-called proximal causes of mortality, we also looked at malnutrition and analyzed and projected malnutrition, not so much as a direct cause, but rather as an antecedent cause or an underlying cause of mortality, for example, due to infectious diseases. It's worth noting, however, that we did omit some important causes of mortality, including type 2 diabetes, chronic emphysema, obstructive pulmonary disease, some chronic cardiovascular conditions, accidents, suicide, to name the main ones. So our list isn't exhaustive, and we are, however, trying to fill these gaps as we go along, especially in the next iteration of the report. Next slide. We did a very, very extensive job of reviewing data, both from before the war, as well as from the period of the war to date. And actually, pre-war data for Gaza, for someone like myself who was more familiar with low-income country settings, were really quite rich and have enabled us to quantify the baseline rather reliably. These data came from the Ministry of Health, from UNRWA, from WHO, and we have continued to track data since the start of the crisis, produced and made publicly available by the likes of OCHA and other UN agencies. We've also drawn on the literature from other settings. We have also carried out some expert consultations for injuries and infections to help us parameterize specific quantities. And we will carry on with this process of ongoing data collection. Again, all those data are uploaded to the website. Next slide. I will go through the methods very briefly because either we can talk about it for 3 hours or not at all, it feels like. But it is worth noting that this hadn't been done before. So for the most part, this is novel methods. If you look at the disease modules or the cause-specific modules that I listed earlier, only for maternal newborn health problems did we actually rely on an existing model, and that is the LIST tool, which I think Hannah will tell us about. For the other modules, we very much developed models and analyses from scratch. And essentially what these try to do is they try to take us from that baseline pre-war to the period to date and the projection period by figuring out how different risk factors and different health service disruptions may be affecting key disease progression parameters or processes, such as transmission, such as case fatality ratio. That is in a nutshell what we have done. Next slide. I've already gone through this, but it's just to say that, again, for each of the scenarios, we have specific values assumed, obviously, of risk factors that are pertinent to one or more of the disease modules that we looked at. Next slide. And I think I will just end with a couple of slides on the overall top line findings, which Paul will pick up on again in the discussion part. So here you can see just a very simple graph of our cumulative projected deaths with time. So remember that our projection period started on the 7th of February, and we're going all the way up to the start of August. And what you can see in the graph is essentially our scenarios, and the escalation scenario on the top, which would take us through to something around 85,000 excess deaths within this 6-month period, versus the scenario at the bottom, which is a ceasefire, where we would project something on the order of 11,000 excess deaths. Now, there's some nuance here, which other colleagues will go into. And I also want to point out that our starting point in terms of excess deaths, when we look at the crisis period as a whole, isn't zero. So we also must factor in here, which isn't shown here, the excess deaths that have already occurred, that had already accrued as of 7th of February. And so really what we're looking at overall is those excess deaths plus the projections that we have made over this 6-month period. Next slide. We are able to break down our projections by age. So what I'm showing here is on the x-axis age groups, and on the y-axis age-specific death rates per 1,000 people per year. And you are seeing the baseline, the pre-war levels, more or less, as the dotted gray line here. And every graph, by the way, is a different scenario. And then you're seeing our actual projections as the colored lines, and the numbers within each graph are the ratios of mortality under our scenario versus under the counterfactual no crisis baseline for each age group. Some of these ratios are very, very stark, mainly because Gaza really had extremely little mortality, at least in non-war periods, within the old sort of adult age groups, and instead most of the mortality was concentrated in the very, very young and in the very, very old. Next slide. Humanitarian actors are most familiar with expressing crude death rates as per 10,000 people per day, and that's what we're doing here. So what this graph shows is that we had a pre-war crude death rate of around 0.07 deaths per 10,000 persons per day, and under our scenarios we are projecting an increase of that death rate to all the way up to about 2.2 per 10,000 per day under the escalation scenario. And you can kind of see in the text box what those relative increases look like depending on the scenario. Now, there's something worth mentioning here as well, which is that as part of our models, what we had to do was to work out the actual projected death rate and the death rate that we would have projected if we had tweaked all of the model parameters to resemble what would have happened in the absence of a war. So we come up with our own counterfactual no crisis baseline, which is actually on the order of 0.05 deaths per 10,000 per day, which is, as you'll see, a little bit lower than the actual empirical measured death rate before the war, which is 0.07. And we think that the difference there has to do with what I mentioned before, omission of a few important diseases from our analysis, as well as, by the way, the fact that we're looking at the summer period, which is also the period of the year with the lowest burden of specific endemic infectious diseases such as COVID and the flu. Next slide, and I believe that I'm done talking, which is a relief, and I'm handing over to Sarah.
All right, so we're going to kick off with traumatic injuries. We're going to briefly just go over the methods. So as Francesco mentioned, we've used multiple data sources. The kind of crux of our methods is from OCHA and as well as from the Ministry of Health in Gaza. So we have essentially the age and sex distribution of those who were killed up until the 5th of January that was released by the Ministry of Health. We have the severity of injuries, and this data was made available up until the 12th of December. We have anatomic locations of the injuries, although this is a very small subset. It really only includes those who were able to leave Gaza for medical care. And then we have the case fatality rates of injuries that we would expect to see in the current Israeli military campaign in Gaza. And we showed these case fatality rates to a panel of experts. And they were essentially able to give us their best guesses of what they thought would happen to these case fatality rates in each of our projected scenarios. And this is kind of how we came up with the projections moving forward. Other things to note within our methods, for the ceasefire scenario, there's also the inclusion of landmines and unexploded ordnances. In this data, we looked further back into 2014 in the post-war period in Gaza to see what happened with landmines and unexploded ordnances. And then we also have complications from injuries which would have been sustained in the period prior to the ceasefire. And the final thing that we tried to look at was those who are uncounted. So the Ministry of Health is really only able to count those who present to the hospital, those presenting to the morgue, but those who are killed under the rubble, those who are unable to be reached by first responders are not accounted for. And so what we did is we looked at those UNRWA staff who are killed under two assumptions, essentially, that they are better accounted for than the general population. And then also under the assumption that they're not more targeted than the general population. Next slide, please. So this is the results. So just looking at it briefly, we can see the amount of lives that can be saved by implementing a permanent ceasefire. So there's a huge decrease in deaths in the ceasefire scenario. And as I mentioned previously, there are some residual deaths from wounds sustained from the previous period. And there's also those who would be killed from landmines and unexploded ordnances. The other thing that I want to highlight within this slide is the difference between the lighter bit of the bar graph and the darker bit. So the lighter portion of the bar graph essentially shows those who are immediately killed, and then the darker portion are those who are killed later, essentially by their wounds. And the darker portion is about 40%, and this really highlights the breakdown of the healthcare system and those deaths that may have been preventable otherwise if there was adequate medical care. Next slide, please. And then this final figure for the traumatic injuries is a layered population pyramid, and it's broken down by age and sex, and the ages are broken down by decades, although we do have this data broken down by 5-year periods as well. And again, just briefly looking at it, the transparent bar graph, or the bars, are the population of Gaza. The colored bars are those who are reported to be killed up until the 5th of January, that report that I had mentioned previously. And looking at it, there is a large amount of overlap between the ages and sexes between the general population and those who are killed. And this really highlights just the widespread nature of the bombing that's occurring in Gaza. Of course, there are some exceptions. So if we look at males between the ages of 20 and 49, within trauma and injury data and literature, these are actually those who are considered demographically likely to be fighters. This is certainly true within the Gazan context, so there are also other things that make this demographic more likely to experience death in this period, and that would be being first responders, being healthcare workers, also being those who are more likely to be outside and collect aid for their families. So the pictures that we saw come out of the Flower Massacre, for example, we do see a large portion of those victims do fall within that demographic. The other thing that I want to highlight within this population pyramid is, again, we do have it broken down by 5 years at a time. So about 32% of those who are killed are under the age of 15, 42% of those who are killed are under the age of 19, and then just overall breaking it down by sex, 57% of those who are killed are males, and then 43% of those who are killed are females. And then with that, I'm going to pass the mic on over to our lead author, Zaina, who's going to talk about malnutrition.
Thank you, Sarah. So moving forward to modeling, we also try to model the increase in malnutrition in Gaza. It's important to note that before the war, 77% of households were reliant on food aid. So food intake and caloric intake was mainly coming from food assistance, and especially in poor households. And what we try to do is actually understand what's happening in terms of the market, so to model the decrease in food available in the market in Gaza over time, based on data coming out from WFP and other agencies, and then also look at agricultural food land decrease over time and intake coming from agricultural land, but also look at what's happening in terms of food trucks, so how many food trucks are coming into Gaza, to understand at the end what would be the caloric intake per person happening currently in Gaza. And so in the first graph, you see actually the food trucks, the data that we have. And we see that before the war, around 180 food truck of was coming daily of food only. There's a clear gap into what's availability of food trucks coming in. And then we translated that into caloric intake in the next graph. And we could see that around in the last period when we did this analysis in February, it was around 1,500 kilocalories per person. So, and this gap is also can be seen when we looked at around 5,300 food trucks reached Gaza during this period. However, before the war, around 17,000, 20,000 would have arrived to Gaza. Then we use these caloric intakes to understand the deficit and look at the weight loss happening using a survey that we've collected before the war among adults, looking at how their BMI is gonna decrease over time, or weight actually decrease over time, weight loss. And we applied this weight loss to also children to understand the increase in prevalence of acute malnutrition among children. It's important to note also that we also used data before the war of children attending growth monitoring within Gaza to understand how this increase in acute malnutrition would happen. So then just to show in the next, slide, it's not decided. Oh. Okay, in the next slide, we see that a bit since the beginning of the war, we tried to project what would be the decrease in weight loss until February. And then for the scenarios, we assumed under a ceasefire that humanitarian assistance would come in and more food trucks would come in, and so the calories intake would increase, but then in an escalation scenario, which is in the purple, that actually the food trucks would keep on decreasing. And what's happening currently is probably resembles much likely the escalation scenario, as the food trucks have been decreasing in the past 2 weeks. And then in terms of acute malnutrition projections, before the war, acute malnutrition, which is wasting, which actually refers to weight for height, Z-scores of less than 2, was around 3%. Up to February, which we project that the prevalence would be around 14%, which is quite critical. In an escalation scenario, in the next 3 months, we would see prevalences of around 24%, which is classified as catastrophic and resembles famines that we've seen in other places. It's important to also note that this is starting to be observed. In 1 week, we saw 20 individuals who have starved and have died and have been reported to die, according to the Ministry of Health. And this is very important as it links directly to what Fiona will be presenting next.
Thanks, Zina. So I'll present on the work that was conducted on the infectious disease model. And so for this model, we use a dynamic model to track immunity to infection and disease. This was work led by Greg Barnsley, who's also on the call. The model was informed by vaccination coverage estimates, vaccine effectiveness, and assumed pre-war natural exposure to infection. In this module, we considered both epidemic-prone and endemic infections. For the 11 epidemic-prone pathogens that were included in these projections, we simulated a large number of epidemics based on starting susceptibility to infection, the probability of occurrence of an epidemic, transmissibility, and case fatality under the 3 different scenarios. We conducted structured expert elicitation to quantify estimates and uncertainty around the probability of an epidemic occurring, reproductive numbers, and case fatality ratios. And to do that, we provided values to experts of risk factors, including malnutrition that Zaina just presented, shelter and WASH, as well as health system disruptions. So we provided these estimates for the 3 scenarios. Then for the endemic infectious diseases, we projected mortality by multiplying pre-war levels by factors reflecting increases in transmissibility and case fatality that were estimated in the expert elicitation as well. The endemic model also accounted for seasonality. On the graph that you can see on the slide, it shows the pre-war trends in the number of deaths due to infections, which were all assumed to be due to endemic infections. And a model was fitted to forecast the counterfactual scenario of no war for values of infectious disease deaths for the projections. And there you can see a picture of some conditions experienced in shelters. Next slide, please. So this slide shows the results for the endemic infections. So it shows the projected excess mortality by an endemic infectious disease, period, and scenario. And in the table, you can see that the total projected excess mortality for endemic infections are around 1,500 in the ceasefire scenario, 2,100 in the status quo, and 2,700 in the escalation scenario. You can also see that there's wide confidence and uncertainty intervals on those estimates. COVID-19, influenza, and pneumococcal diseases are expected to be the leading causes of death in the endemic infections. And this reflects the fact that the majority of infectious diseases before the war were attributable to pathogens transmitted through the airborne droplet route. For some diseases, you can see that the excess deaths are expected to be lower in the months 4 to 6 than in the 1 to 3, and that's due to the effect of seasonality, which was included in the modeling. Next slide, please. On this slide, we present findings for the epidemic diseases, and overall we project that about 5,000 excess deaths due to epidemic diseases in the ceasefire scenario, 8,400 in the status quo scenario, and 11,500 in the escalation scenario. But you can see there's wide uncertainty intervals that are inherent, that are due to the uncertainty in the modeling. And the projections suggest that cholera, measles, and polio and meningitis pose the greatest mortality threat, with substantial mortality potentially occurring under the 3 scenario, mostly due to disruptions in including overcrowding, inadequate WASH, and on the ongoing nutritional emergency that Zaina spoke about. On the because of the large uncertainty in the projections of epidemics, we also show the estimated probability of the occurrence of an epidemic in this graph, which so it shows the probability of an epidemic featuring more than 100 deaths by disease and scenario over the 6 months period. And as you can see, the probability of an epidemic occurring is fairly low. The highest probability is for cholera and measles, ranging around 10 to 18%. But whilst the probability is low, if epidemics were to occur, then the projected excess death would be very high, like with cholera, up to 100,000 deaths in the escalation scenario. That's it. I'll pass on to Hannah to talk about maternal.
Thank you. So the LifeSave tool was used to estimate the additional maternal and neonatal deaths in stillbirths due to disruption of access to antenatal care, health facility, childbirth care, exclusive breastfeeding, and deterioration in wash and food security status. To give a quick overview of the model starts with baseline level of maternal and neonatal mortality and stillbirth rates and the respective cause of death structures. The model projects number of deaths expected to occur given changes in intervention coverage or risk factors. And the model assumes a linear and fixed relationship between inputs and outputs, which is specified in terms of the efficacy of the intervention in reducing the cause-specific mortality. Table here shows the main intervention considered for this analysis and the mortality rate each intervention targets. For certain intervention during ANC and childbirth, the coverage is estimated based on attendance to the facility and also the readiness of the facility to provide the intervention. And we consider the readiness by availability of commodities such as antibiotics or magnesium sulfate, and by availability of skilled staff to perform the manual procedure. So aside from disruption in access to ANC visits and delivery in health facility, different levels of disruption were also projected for the two types of readiness shown by different coloring of the intervention in the table. Next slide, please. So this figure here shows projected number of maternal, neonatal, and stillbirth deaths for each scenario during the 6 months projection period, divided into deaths that would have been expected under counterfactual pre-war condition shown in gray, and the additional deaths due to decreases in intervention coverage and degradation of the environment and food security with uncertainty bound shown in colored. Pre-war levels of maternal and neonatal mortalities were relatively low. Had these pre-war rates continued, the corresponding number of deaths in 6 months would have been 8 maternal, 335 neonatal, and 340 stillbirths, respectively, shown in gray in the graphs. With the severity of the scenarios, the number of additional deaths increases. In the full report, we also present the contribution to excess mortality of disruption to different public health interventions. But to note again, this figure does not include deaths due to traumatic injury. Despite these groups constituting small subset of the population, their deaths contribute significantly to measures of disease burden, such as years of life loss, and deaths of parents, especially mothers, pose substantial risk to the further survival and well-being of children. Next slide, please. So this figure here shows the cumulative maternal, newborn, and stillbirth mortality, again, all excluding traumatic injury deaths by month and by scenario. The gray line shows a counterfactual trend based on pre-war mortality. We assume the same level of disruption under 3 scenarios in the months 1 to 3 and months 4 to 6, showing here as straight lines. When comparing projected mortality numbers in the scenarios with the historical trend of mortality, these scenarios sets Gaza back by 10 to 20 years of health progress. And in the escalation scenario suggests a prime return to mortality numbers and rates not seen for nearly a quarter of a century. In the absence of medical care, pregnancy, childbirth, and the postpartum period are risky time periods for women and neonates. So it is crucial to have those targeted health interventions to support maternal and neonatal health in the context of conflict. With that, I will pass over to our next panelist.
So as for NCD, our current NCD model projects excess mortality for critical NCDs such as lung, colorectal, and breast cancers, ischemic and hemorrhagic strokes, ischemic heart disease, type 1 diabetes, and chronic kidney disease. So key high burden NCDs such as type 2 diabetes and COPD are omitted from the current analysis. And this is because type 2 diabetes mostly leads to the deaths via CVD cases, and thus may largely be captured by CVD mortality figures. So altogether, the NCD conditions included in our current analysis accounted for about 70 to 80% of all NCD deaths according to the MOH data. Then as for the projection method, so based on the relative survival rate quantified through the literature review, we first fitted the survival curve. So we calculated the hazard rate for the acute phase and long-term survival of each NCD. So as you see from the figure, we collect the data on survival rates with and without treatment, and also their upper bound and lower bound. Then we use distribution to feed these survival curves. We then express both the crisis and the counterfactual deaths in terms of the prevalent treated and untreated cases and their relative risk of deaths, and with changes in treatment coverage rate. And excess deaths is the difference between the crisis and counterfactual deaths. And assumed changes in the treatment coverage rate over time are varied across 3 scenarios. So one thing to note is that assumption for the treatment coverage rates are based on the pre-war data, expert knowledge, and the conversation with the health actors within the Gaza. Next slide, please. So as you see in the results figure, grid bar shows the baseline deaths reported by the MOH, and color bars are the excess deaths. So the primary cause of excess mortality within the NCD domain is due to the ischemic heart disease. So in the escalation scenario, it actually accounts for around 76% of all NCD excess deaths over the 6 months projection period. So as we see from the results, healthcare shortages not only drive elevated chronic disease mortality, limited cardiac care access directly contribute to the increased heart disease mortality risk, while surgery and neurologist shortages elevate stroke risks. Similarly, disruption in the insulin supply are fatal for individuals with type 1 diabetes, and the absence of the timely cancer treatment allows the disease to progress unchecked. Also, complications from the chronic kidney disease worsen due to the missed dialysis sessions. So therefore, we can see that the worst effect on NCD mortality is twofold. It severely disrupts the healthcare system's ability to provide necessary treatment, and then increase the risk of acute exacerbation of NCDs and mortality risk. And this is all about NCD, and I will hand over to Hannah to talk about the mental health.
Thanks, Gigi. We didn't model mental health in this report. Maybe we include it in the next one, but it's critical to underscore a few key points. Pre-war, occupied Palestine, including Gaza, is considered one of the highest burdens of mental health issues and psychological disorder in Eastern Mediterranean region. During the last 5 months, the population in Gaza has been living with the horror of war, and it's ongoing. Every Palestinian in Gaza lost someone or something, a family member, a friend, a house, a part of their bodies, or even an education or job. And this results in high incidence of mental health illnesses. An important immediate concern is the safety and continued care of psychiatric patients, including those living in hospitals and institutions. Israeli forces bombed the only psychiatric hospital in Gaza Strip, serving all the governorates, and was out of services since November 2023. More than 485,000 people with diagnosed mental health disorders were out of medication, in addition to at least 20,000 people in need of specialized mental health services and mental health drugs. It can only assume that these numbers will continue to rise. As we know, intimate partner violence is known to increase in conflict setting, and it's known that intimate partner violence was high pre-war in Gaza. This is another area of great concern. Next slide, please. The psychiatrist conceptualized that in Gaza, there is no post-traumatic disorder because the trauma is repetitive, ongoing, and continuous. The trauma of Palestinians in Gaza includes chronic trauma, intergenerational trauma, as well as acute trauma, similar to what happened during or shortly after the war. For example, 16 years of childhood in Gaza means that child is 6 years old. UNICEF has described Gaza as currently being the most dangerous place to be a child, and the statistics support that between 17,000 to 18,000 children have lost one or both of their parents and left to continue their lives without caring and financial support. Hand over to both.
Thank you, and thank you, Hanan. That was really powerful. I will try to be quick because I would like to, even though we've been trying to answer some questions, I know there will be other questions. So these are the projections, the overall projections, and of course you can go through them. So I won't concentrate too much on this, except to mention that we did try to at least have those with epidemics and then the projections excluding epidemics, because epidemics occur or do not occur. And then with the epidemics, the uncertainty level rises. Next slide, please. So what are some of the key messages? For ceasefire scenario, perhaps it is self-evident, but there still will continue. Even if there's a ceasefire tomorrow and over a 6-month period, there still will be many deaths. And that's because of the lack of the degradation of the hospital and the healthcare system, the logistics and the amount of food, water, medical supplies that are needed. Perhaps not surprising, the majority will be infectious disease deaths, but there still will be trauma injury deaths, both because of the injuries and then the lack of care for them, as well as potentially landmines and unexploded ordnances. The status quo scenario, and also with the escalation scenario, perhaps not surprising, it's going to be much more trauma related. So those will be the highest number, but then followed by infectious diseases. We talk a lot about infectious diseases and trauma. The maternal and neonatal, together with the non-communicable diseases, are smaller numbers, but equally important, of course. And we're all aware of with maternal deaths the effects of the reverberation of these effects to a family and communities. So regardless of the scenario, malnutrition is critical. Francesco, I saw, answered one question. And in our next scenarios, we want to bring in very specifically how malnutrition, as well as water and sanitation, will exacerbate the various deaths. I mentioned the wide intervals. Okay, next slide, please. So these are our key messages, and there, of course, are so many. The political and security agreements are imperative to ensure that security of healthcare and facilities. The attacks on healthcare have been healthcare and health workers have been quite extraordinary, and so we need security agreements to be able to ensure that this stops. Furthermore, there needs to be some sort of security agreements to be able to ensure that civilians have a safe space, that they are able to access care and then also leave the hospitals and the healthcare centers. So deconfliction agreements are incredibly important. Still within the ceasefire scenario, there's going to be potentially projected 6,000 to 11,000 excess deaths. And we've been speaking to numerous humanitarians. We've been speaking to many policy and decision makers at various levels to ensure that this is understood. And this last side, in terms of the ceasefire, when we compare to an escalation scenario, the ceasefire may save approximately 68,000 to 74,000 lives, which is, and maybe I'll end just by saying, and what Francesco mentioned early on, statistics are quite impersonal, and every life we're talking about, there's a person, family, community behind them. So with that, I'll stop just to say thank you to all of our colleagues who have worked so incredibly hard on this, and particularly thanks to Zena and Francesco leading this. I think last slide, which is just questions.
Great, thank you, Paul. And thanks everyone for posting your questions in the Q&A. Please continue to do so. We have a couple of minutes now at the end for some questions. I might start with this question here around transferability. What is the transferability of these novel methods for future crises? Do you have any plans to try and replicate this process in other countries, or do you feel there is scope for a more standardized process of estimating mortality through projections to inform humanitarian action and advocacy efforts? Who would like to take this question? Anyone? Francesco, yeah.
Try. I think I have no doubt. I think that we will probably be asked if there's any way to replicate this elsewhere, and this was to some extent one of albeit a very small reason for undertaking this project, in that this kind of question really is pertinent for other crises as well. I think one challenge with replicating this elsewhere will be the stark difference between Gaza and other settings in terms of the quality and quantity of data, and specifically pre-crisis data. So I don't quite know, to be honest, how we would surmount that obstacle in other places. But broadly speaking, I can say that yes, once we do take a breath and maybe complete this project, we will be looking at how we can generalize this for other crises.
Great, thank you, Francesco. Any other additions to that question before we continue on? Okay, we'll move on to the next one. Question here. Under the ceasefire scenario, what assumptions have been made about the return level and breadth of health services? Who would like to take this one?
I think Hanan and Paul, you were closest to setting those values. Why don't you have a go?
Hanan, do you want to have a go, and then I can, if I need to, I can come in?
Yeah,
or if you'd like. Okay.
Well, we assume that the healthcare services will be restored gradually because like many hospitals and specialized healthcare now is like out of services in Gaza. And we take in consideration there's like many field hospitals exist and will exist in case of the ceasefire. We assume that the healthcare services will still overwhelmed with the traumatic injuries even after the ceasefire, and caring like people with severe ones. Then after like few months, few weeks, and with the full and continuous humanitarian assistance, especially from international community to the healthcare system in Gaza, the healthcare system will be restored and start like functioning, I think almost like 90 to 70% of a pre-war baseline. Over to you, Paul.
Thank you. That's perfect. Thank you. Nothing to add.
Great, thank you, Hanan. A question here. Many others are glad to see this session come up. I immensely appreciate the work you're all doing. Are there ways that students can get involved to help or further research? Zaina, do you want to take this one?
Sure. So a lot of this has been from students who volunteered during Christmas holidays and to actually spend time extracting data and supporting. And so please email us if you want to be involved in this, but also in other work that the Health and Humanitarian Center has been doing. I know actively there's a current study coming up on Sudan, and I'm sure they would also appreciate if anyone wants to volunteer their time into some of these aspects. I'm sure the Sudan team would also, the people studying on Sudan, to email Maysoon Dahab about that. Thank you.
Thanks, Zaina. A question here about ethics approvals. Considering that ethics approvals come from Western universities, how would researchers reflect on their understanding of the ethics of doing such research during an ongoing war? And a second question from the same person, also, how did you factor in your projections that Gaza's population are mostly refugees? Who would like to take this one? Francesco?
Okay, so the latter one is easy to answer. I mean, they're not refugees, they're internally displaced so far, for the most part, right? And essentially, we specified different levels of displacement as part of our scenarios. And really, by and large, this would mainly be relevant, not only, but mainly for infectious diseases and for transmissibility of infections, in that people are living very, very close to each other and in unsanitary conditions. So we asked the panel of experts that we sort of had help us, as Fiona mentioned, quantify some of the transmissibility parameters to also take into account the patterns of displacement. On the former question, well, we haven't really have had the opportunity, I think, to consult very widely with people that are extremely closely affected by the crisis. I mean, some members of the team are, but the nature of this project and its very, very tight timeline has meant that, to be perfectly honest, we have gone into the work with an assumption that this was a good thing to do, that this had, on balance, a positive ethical value, hopefully. And now what we have agreed as part of the project is that a separate team would evaluate the utility and perceived impact of our work. And we will hope, of course, that that team will not just look at how our findings are used, but also expose us to some extent to any critical appraisal of what we're doing, how we communicate, how we present our work, how we engage on it. I also just want to encourage everyone to share any constructive feedback on what we could be doing better. We have the inbox that I signposted to at the start of the presentation. I think this is a very, very ethically fraught space. There's no shying away from that. But we are still hoping that what we're doing on balance will be beneficial, as I mentioned at the beginning of the presentation, by making sure that the universal principle of putting lives at the center of decision-making is adhered to. Without these kinds of projections, arguably that would not be as easy to do, right? Because you could say, well, there are no numbers. We don't know how many people will die. We don't know what will happen. So then other priorities perhaps take preeminence, or other factors become more important or more attractive, I suppose, to consider in a decision process. And what we are actually trying to make sure with this work is in fact, people who are taking decisions be they humanitarian or diplomatic, political actors, are doing so with a clear understanding of the implications. That's the easiest thing that I can say somewhat naively to sort of defend the ethical foundation of our work.
Thanks, Francesco. We've come to the end of our Q&A. I'm just going to hand back to Paul to wrap up for us. Thank you.
Thank you. I would maybe just follow with what Francesco said, is that this has been a journey. It's been complicated. Some had asked about the aspects of the report and neutrality and how to navigate that. I think we've all been struggling with many aspects, and it's been a learning experience. And so I would follow with what Francesco said, that we'd like to have feedback. We'd like to learn more about what we could do better and what you think, what else we can do. And that's it. Thank you very much. Excuse my thing. Thank you very much for all of you for attending today.
Thanks, everyone. Thanks for joining. The recording will be up on the Health and Humanitarian Crisis Centre website at the end of the week. Thanks for joining.